Oops. Maybe we did it right this time. In here it's easy. It's just
well, I'll just like look at you with confusion.
Yeah, that's fine. If you need help, you should be good.
Hi everyone. We're gonna get started. Can you guys hear me? Yeah. Okay. So I'm Dr Castro. For those of you who don't know me, I'm one of the second-year pulmonary critical care fellows, and I'm going to talk to you guys today about DKA. So the objectives for this talk, so this is mainly just to review how to recognize DKA and how to diagnose it. Then we're going to describe the DKA fluid and insulin management. And then we're going to compare and contrast DKA to hyperosmolar hyperglycemic state, or HHS. So we'll start with a patient case. So this is a 19-year-old female, history of type 1 diabetes, who presents with back pain, nausea, vomiting, and her glucometer reading high. She had a recent course of antibiotics for pyelonephritis. Her vital signs are here in the emergency room. So she's hypertensive, tachycardic, tachypnic, normal stat with and she's afebrile. On exam, she's in moderate distress. She's got dry mucous membranes. Her abdomen was soft and non-tender, but she did have left costovertebral angle tenderness. And so, I mean, I'm sure you guys have an idea what's going on, but we'll come back to this. So this is just what's going on with her, but we'll come back as we go along. So why do we care about DKA? So it is a potentially life-threatening condition. And the higher risk of death happens in the more likely in the elderly patients with multiple comorbidities. So this is for the epidemiology, basically. This data is from the CDC. The most recent polling they did was in 2014, where they had 168,000 people admitted for DKA, and that came out to about 7.7 or 8 persons per 8 people per 1,000 persons with diabetes. And although most patients had type 1 diabetes with DKA, up to about a third of them, 34%, can have type 2 diabetes as well. So this can apply to all of our diabetic patients, basically. So what is DKA? So it's a potentially life-threatening complication of diabetes that's characterized typically by the classic triad of 1, uncontrolled hyperglycemia, 2, metabolic acidosis, and 3, increased total body ketone concentration. But more specifically, the diagnostic criteria, the blood sugar is greater than 250, but as I mentioned here, you can have euglycemic DKA as well. So actually, you don't have to have this first one. So be wary when you have kind of like a high anion gap, your ketones are elevated. If they are diabetic, they could still be in DKA. pH is typically less than 7.3. Bicarb, usually less than 18. And then, as I mentioned, the ketones are going to be high, so this will either be present in the urine, in the urinalysis, or in the serum. This can be measured by the beta-hydroxybutyrate as one of the ketones that's formed during DKA. And your anion gap is going to be elevated because of these ketones. And it's always important to think about if the patient has a lower albumin, you have to correct for that. The expected anion gap, like a quick shortcut, is if you take the albumin and multiply it by 3, that's your expected. So if your albumin is lower, your normal anion gap will be lower than the normal 10 to 12. And we'll talk a little bit more about this as we go along as well. So this is from the ADA guidelines in 2009 that basically explains the pathophysiology. So what's going on in DKA? So you have, in type 1 diabetes, absolute insulin deficiency. You don't have any insulin. And basically then you're not able to bring the glucose into the intracellular space to utilize that for energy. So instead, for energy, you take down your fat and you break that down into free fatty acids in the liver, and that breaks down into ketones. So that basically is what causes your ketoacidosis. And then also the fatty acids being broken down, you get hyperlipidemia. That's why these patients are, usually have more hyperlipidemia and increased risk for coronary artery disease. And then also on top of that, you have high glucose, you can't utilize it. It's just a very stressful situation. So you have a stress response with your counter-regulatory hormones. Your cortisol is going to be high. And so that basically also breaks down protein for energy into gluconeogenic substrates. And you have, even though you have a high blood sugar, you're making even more glucose. And then in a stressful response, you'll also have upregulate your glycogenolysis as well. And as I said, you can't use your glucose, so all of the three of these contribute to hyperglycemia. In result, with high blood sugar, you urinate that out. You have an osmotic diuresis with the sugar follows water, and you'll urinate, and that's what causes your loss of water and electrolytes. Significant dehydration. They're not able to eat as well, too, because they're not feeling well, and that all contributes to hyperosmolarity. And then, of course, with the dehydration, you have a prerenal state, you have impaired renal function. So that's kind of more DKA here on the left. And on the right, with HHS, you have, in type 2 diabetics, you have more of a relative insulin deficiency. So you have the insulin, but tissues are less responsive to it. So you actually have enough insulin to suppress the ketogenesis. So there's less of that acidosis and the elevated ketones in HHS, but you will still have this hyperglycemia, the stress response, and the hyperosmolarity. And so this is just what I just talked about, but basically in a picture for those of you who can't like pictures better. So this is basically just showing fat you're breaking down, protein you're breaking down into their substrates that all lead to either ketones or hyperglycemia, as I had mentioned. So basically worsening your hyperglycemia and your acidosis. So we're going to have a few pop culture trivia breaks here. So this is celebrities with type 1 diabetes. So who am I? I was in a band with my brothers. Yes, I think that was Lakshmi. Yeah. Hit song, Jealous. I'll just go through the rest. And I'll give you something later. Engaged to Indian actress in Miss World 2000, Priyanka Chopra, so we know. Thanks to Lakshmi. Nick Jonas. Good job. All right, so typically these patients will present, they'll tell you their glucometer is reading high, and that's actually what it reads. So if your blood sugar, depending on what the glucometer is, 400, above 400 or above 600, it's too high for it to measure, so it'll just say high. So they'll have the usual, polydipsia, polyuria, weight loss, you guys know all this, abdominal pain, nausea, vomiting, weakness, and then change in mental status. And this is usually more of an acute presentation within, 24 hours or so, that all of these symptoms will kind of develop kind of pretty quickly. So triggers for DKA, here I listed some common ones. So whenever you're assessing your patient and taking a history, kind of keep these in the back of your mind because you have to figure out the etiology. So if it is something reversible that you can treat it. So infection is the most common etiology. So, upper respiratory infections, UTIs, inadequate insulin therapy. So maybe they're not on insulin yet and they need to be, or if they're on a dose that's low and they actually need more. And then medication noncompliance, that's a common one that we'll see here as well. So we always have to kind of get a good idea of how compliant they are. Pancreatitis, I'll always check a lipase. And actually myocardial infarction is a common one. So every patient, even though they're not having chest pain, as you know, diabetics can have atypical kind of chest pain with abdominal pain. Get an EKG and a troponin for all these patients. Stroke and illicit drug use. Cocaine has actually been one of the drugs that have been commonly associated with eliciting DKA. And as I said, this is a stressful, kind of like a stress response. So if you have like a trauma or a surgery, this can trigger it. And of course, if they're undiagnosed and they have type 1 diabetes, this could be their first presentation. And if they're a known diabetic with type 1, they have an insulin pump, check to see if the pump is functioning correctly. And then certain drugs can cause DKA as well, some atypical antipsychotics. And certain sympathomimetic drugs can also precipitate DKA. So on exam, so these patients are really dehydrated. So you'll have poor skin turgor, the Kussmaul respirations. This will be the kind of, deep labored breathing that they're basically trying to compensate for that severe metabolic acidosis that they have. They're trying to hyperventilate. They'll have a fruity breath odor, and I've encountered this only a few times, but it actually will smell like a little bit like nail polish remover. This is from the acetoacetone, is one of the other ketones that are formed in addition to beta-hydroxybutyrate, but that we don't typically measure. Tachycardia, hypotension because of the dehydration. They can be altered with more of a lethargy picture, and abdominal pain is a common thing, so they can have abdominal tenderness on exam. So this is the typical laboratory findings, which we talked about on the previous slide, and you guys probably all know this, but this basically breaks up DKA in class of severity, so mild, moderate, and severe. And you typically just look at these top two, the arterial pH and the serum bicarb. And we don't always typically get an arterial pH unless you're really concerned about what the pH is. Usually a venous blood gas will be adequate. So if you're between, 7.25 and 7.3 and the bicarb is between 15 and 18, that'll be mild. And then you can just read here. And then severe is if they're less than 7.0 and bicarb less than 10. And the rest we kind of already talked about. You'll have the ketones, the osmolality can be variable in DKA, and the mental status will be affected. So going back to our patient case, this is the lab. So they actually got an ABG on her. So the pH was 7.10, PCO2 is 15, PO2 was 200, O2 stat was 98, beta hydroxybutyrate was 8.6, lactate was 12, and the albumin was 3. So I have the labs there. You can see sodium of 128, chloride was 96, bicarb is 5. So the glucose was 600. She's got a white count elevated 21,000. The diff on that was 82% neutrophils and 3% bands. So looking at here, what does someone tell me what the anion gap is? Just shout it out. Yeah. So it is 27, but also the albumin is 3. So so you have to correct for that. As I said, there's a couple ways to do this. Like I said, you could do albumin times 3 as you're expected, but also for every 1 point of albumin below 4, you can add 2.5 to your anion gap calculation. So that would be actually like 29.5 or 30. And then what is the actual corrected sodium? Just a ballpark. Yeah, good, thank you. So we'll go over this in a second. So the anion gap, just to remind everyone, you do sodium minus chloride minus bicarb, and you do not use the anion gap that's reported in EPIC here because that contains the potassium in it. So you can either subtract the potassium or just calculate it yourself. Normal range in a normal person, 10 to 12, but as I'd mentioned, this is just for you to read it up here. So for every 1 point of albumin below 4, you add 2.5 to your anion gap calculation, or expected is albumin times 3. So other common laboratory findings, pseudohyponatremia. So it's how to correct for the sodium. And this is because, your blood sugar, glucose, water will follow it and dilute your sodium. So actually you take for every 100 above 100, you add 1.6 to the measured sodium value. And it's important to use this, like the lower sodium values, not the corrected sodium value for your anion gap calculation. This is because glucose is neutral and doesn't affect your anion gap. So just use whatever is reported on the BMP for your anion gap calculation. Patients can also have a falsely elevated potassium on the BMP. This is because your lack of insulin causes, and the acidosis causes the potassium to be in the extracellular space. So it can look like their potassium's high, but really everyone in DKA is potassium depleted because of the fluid losses that they're having with their osmotic diuresis. And then lastly, leukocytosis is very common in DKA. This is because, like I'd mentioned, it's like the stress response. It's a stress reaction typically. But if their white blood cell count is above, 25,000, that's pretty high and atypical for the stress reaction part. So you always want to think about ruling out an underlying infection that might be causing that, and considering if the patient needs empiric antibiotic therapy while you're trying to figure that out. Okay, so how would you describe the patient's acid-base status? Someone just yell out something. So acidotic, alkalotic. Yeah, is it respiratory, metabolic? Okay, so metabolic acidosis, and then is it adequately compensated? Yeah, so it is. So, if you have metabolic acidosis, then you'll want to do the Winters formula to calculate if it's adequately compensated by hyperventilating your PCO2 down. So the expected PCO2 is going to be 1.5 times the bicarb plus 8, plus or minus 2. Her bicarb was 5, so that brings you to 15. and that was actually what the patient had. A PCO2 is exactly 15, so she's adequately compensated. Oh, and this is just to show you what I did. So 600 has five 100s above 100, so you did 5 times 1.6. That gives you the 136. Okay, so that was boring. So who am I? I am an actress. I had my own TV sitcom in the 1970s named after me, where I played a local news producer. Also starred in the Dick Van Dyke Show. Yeah, watch me. Okay, good. Okay, so where do you triage these patients? So the short stay unit can take DKA patients, but this is usually kind of really mild cases. They think the cutoff for short stay is 18, and the anion gap has to be typically closed on one occurrence because they can't do the Q1 Accuchecks for more than 4 hours on short stay unit. So you can take a patient if they have this to the short stay. And step down unit or CP4 will be where you have most of these patients because they'll have to, the Q1 glucose checks is really and that they need closer monitoring for. And then MICU will take these patients as well, but this is usually if the patient is severely acidotic, pH is less than 7, or if their mental status is just really poor and you're worried that they might need intubation for, not able to protect their airway or a low GCS. And so, of course, if they're a known diabetic, it'll be kind of more straightforward, but if their glucose is normal and they have this high anion gap and their ketones are up, you want to think about other things that could be going on. So it could be a starvation ketosis or an alcoholic ketosis as well. And then, of course, if it's just like a really high anion gap, you want to worry about the osmolar gap to see if they've had any other ingestions like salicylate, methanol, ethylene glycol. Think about those in the back of your head as well. So if you guys texted in, this is the first question. So what is the main role of insulin in the treatment of DKA? Hold on. So A is decrease blood sugar. B is increase the serum insulin concentration. C is suppress ketone production, or D, none of the above. Okay, I think everyone in? Yeah, so majority got it correct. So yeah, it's to suppress the ketone production because I'll talk about this, but that's the main thing that's making the patient sick is the acidosis. So you want to make sure that you slow that down. 30. Okay. So then we'll move to the treatment of DKA. So I broke this up into 5 parts. So 1 is management of volume depletion. 2 is electrolyte imbalances. 3 is inhibit ketone production. 4 is management of glucose. And 5 is identifying the underlying etiology. So volume depletion, what fluids do you order? So like I said, these patients, the first thing that they come in with is just they're hypovolemic. They could be in hypovolemic shock as well. So isotonic fluids are used first. So because you're fluid resuscitating them, you want to use isotonic fluids to expand their extracellular volume. The ADA guidelines say normal saline is recommended for your initial fluid resuscitation. You can consider lactated ringers if the patient already has a non-anion gap metabolic acidosis, because normal saline can worsen non-gap acidosis. And what about bicarbonate? These patients are really acidotic. Do you give them bicarb? So the use of bicarb in DKA is actually pretty controversial. The ADA guidelines say that you can give like 2 amps of bicarb over 2 hours if they have an arterial pH of less than 6.9. But also just consider it if they are hemodynamically unstable, hypotension, if they're having arrhythmias from the acidosis or seizure. you can give it. So, but it doesn't, there's side effects for the bicarb. It can cause hypokalemia, decreased tissue oxygen uptake, and cerebral edema has also been associated with bicarb administration and DKA. So typically we don't do it. So how much fluids do you give? So if the patient's in shock, like I said, these patients can be in hypovolemic shock. You want to give isotonic fluids as rapidly as they need. If the patient's normotensive, the ADA recommends to give 15 to 20 mLs per kilo per hour, and a 70 kilo person, that comes out to like 1 liter per hour. This is, of course, in the absence of any like heart failure or cardiac compromise. You can consider doing this in your initial resuscitation phase. So once the patient is adequately resuscitated, you want to transition to maintenance fluids. And the guidelines say that you can choose between half normal or normal saline, and they want you to do that based off of the patient's corrected sodium at that time. So if you do the sodium correction and the sodium's still low, you can continue normal saline at a maintenance rate. If the sodium is normal or high, you can change to half normal saline. And then again, the lactated ringers you can use, or sodium bicarbonate like infusion, not like the bolus, can be used if the patient has a non-gap acidosis. And just kind of be a little careful with too much aggressive fluid resuscitation. You can cause, iatrogenic fluid overload. The patient can go into pulmonary edema, or you can develop a hyperchloremic non-gap acidosis. So if you have a high chloride load, you lose a bicarb, you get an acidotic, so it might look like the patient's not getting better. But this is a benign condition that will self-resolve. So this is, again, the patient's labs. Sodium 128, potassium 2.9, creatinine is up. So I think the next is the question. Yeah, so what is the next best step at this point? So you get your labs. Is it, how do I go to the next? Next, okay. Thanks. Oh, yeah. Okay, so what is the next best step? So A, administer ceftriaxone. B, administer potassium chloride. C, administer sodium bicarb. Or D, start insulin. Okay. We're split between start insulin and potassium chloride. So the correct answer is B, administer potassium chloride. If you looked, the patient's potassium was 2.9. So if your potassium is below 3.3, you have to hold the insulin infusion because, as you know, potassium will insulin will drive potassium into your cells, and that will worsen the hypokalemia. So you have to replete the potassium until it's above 3.3, and then you can start your insulin infusion. And then, as you know, with the continued insulin infusion, you can still precipitate more hypokalemia. As I'd mentioned, all of these patients are potassium depleted. So you can add potassium chloride. It's a 20 milliequivalents per 1 liter of fluid. You can just order your fluids that way while the insulin is running. You want to replete your magnesium, too. If your potassium's low, you want to have your magnesium above 2. And the phosphorus will also be depleted. So the guidelines say that if your phosphate is less than 1, then to go ahead and replete it. And you can add potassium phosphate to your fluids as well. So, and then 3 is the most important thing, is to inhibit the ketone production. So that'll be done by insulin, so that you can, give your insulin, you can utilize your glucose instead of making ketones. So the dose, it's a regular insulin that you would order. It's an infusion. The starting dose is 0.1 units per kilo per hour. So this is the dose that's supposed to saturate all your insulin receptors so that you suppress ketogenesis. So any dose below this, you could still have ongoing ketogenesis. So just kind of be careful in the beginning especially. So while you have your insulin drip going, you're going to order BMP every 4 hours. Make sure it's a stat order, and you're doing this to monitor your anion gap, which reflects the ketones. You also want to check on your electrolytes, your potassium, magnesium, and then the renal function. And the insulin drip is continued until your anion gap is closed or normalized on 2 subsequent BMP. So the first one's just to show that you're, that you're there, and then the second one's to show that you're staying closed and you're not making any more ketones. So, you start your insulin drip for your patient. Well, you give the potassium, you start your insulin drip, and the nurse comes up to you and says, the patient's blood sugar is 110. The insulin drip is at 7 units per hour, and she's 70 kilos. Normal saline is running at 150 an hour. The anion gap is 27. What do you want to do next? So A, no change in management. B, decrease the insulin drip. C, discontinue the insulin drip. Or D, add dextrose to your fluids. Oh, man. Everyone says to add dextrose to your fluids. And that's what I would say is the right answer. But there's actually no right or wrong answer to this. That is actually the best answer because your anion gap is still so high. But technically, you have liberty to play around with the drip, and I'll talk about that in a little bit. So, no, we don't typically give a bolus of insulin. That's a good question. So as you know, with the insulin drip, your hyperglycemia is going to improve. And this will happen faster than your anion gap will improve. The ketogenesis will still be ongoing and your blood sugars will drop. So once the EDA recommends that once your glucose reaches the 200 range to add 5% dextrose to your fluids. So this will allow you to continue the insulin drip where you're at. Like I said, that 0.1 is the best to saturate all the receptors and inhibit your ketone formation. So just adding the dextrose will allow you to keep your insulin drip the same while avoiding hypoglycemia. If you decrease the insulin drip prematurely, you can have, like I mentioned, still ongoing ketogenesis. We've had a lot of patients go backwards and their anion gap opens up if we decrease the insulin drip prematurely. So don't be afraid, add dextrose, go up on, the rate, do 10% dextrose if you need to kind of make sure that your anion gap is going in the direction that you want it to go. So when do you transition to sub-Q insulin? So once the anion gap is closed on 2 occurrences, the patient feels hungry, they want to eat, and ideally if their glucose is less than 200, you'll want to, stop that NPO order, give the patient a diet, and give them their long-acting subcutaneous insulin. Most people are on glargine, so usually we'll give that, or whatever they're on at home. You'll just want to resume that. And you want a 2-hour overlap. So, give the sub-Q insulin, wait for 2 hours, keep the insulin drip going during that time, because you want to make sure that that sub-Q dose that you gave is absorbed. And then after the 2 hours is over, you can stop the drip, insulin drip, you can stop the maintenance fluids, and just let the patient be more normal. So you can stop the Q and hour AccuChecks, change them to mealtime and bedtime, and stop the scheduled BMPs. And then there's just like a quick, underlying etiology, ask for the insulin compliance, do your infectious workup as indicated, always check that EKG and troponin, and more, elderly patients at risk. Check a lipase throughout pancreatitis, but use your history to guide your workup. So you can have complications with GK management, of course. As I mentioned with the insulin drip, you can have hypoglycemia and hypokalemia. Cerebral edema is a well-documented adverse event in pediatric population. This rarely does happen in adults, and it's just mostly case reports. But basically, you have all the fluid shifts, the hyperosmolarity in the brain, you can have develop cerebral edema. And then thromboembolism. So DKA is, like I said, it's an inflammatory state. It's also been shown to be prothrombotic, so you can have thromboembolism with it as well. We have one more. Who am I? So I was the lead singer of the band Poison. Hit song was Every Rose Has Its Thorn. I had a reality TV show on VH1 called Rock of Love. Yeah. Right, Michael. Okay, so just going to talk briefly about HHS. So this is characterized by, you'll have severe hyperglycemia, greater than 1,000, way higher than DKA. And the hyperosmolality, also dehydrated, but the one thing that distinguishes the two is the absence of the significant ketoacidosis. So this most commonly happen in patients with type 2 diabetes. So as I mentioned before, you have insulin, the tissues are resistant to the insulin, and they're present, so you have enough to stop, like you're not making ketones, but it's not enough to utilize glucose as you would normally would. So as I mentioned, glucose is usually greater than 1,000. So in this case, that causes a profound osmotic diuresis. So that's what leads to your hyperosmolality. And these patients can present with seizures, actually. They can have more like neurologic signs. We just had one recently in the MICU that presented with a seizure. And this is because of the high serum osmolality. So you go to hemianopia, hemiparesis as well. And this is the labs that you'll typically see. They wrote on here, usually greater than 600. Your pH is going to be above 7.3. Bicarb is going to be above 18. You can have still small amount of ketones, but it's not going to be really that significant. And your serum osmolality is going to be above 320. You can have an anion gap, and this is more of the mental status is worse, more of a coma or stupor. So it's just putting them next to each other so you can kind of compare the two. So DKA is going to have the ketogenesis, HHS underlying problems, the osmotic diuresis, and the dehydration. Presentation for DKA, as I'd mentioned, more of acute, 24 hours. HHS can start to be brewing in a bit of a longer time period, days to weeks. More acidotic in DKA, normal pH, normal bicarb in HHS. Ketones are higher in DKA, and the osms are higher in HHS. Anion gap is going to be variable in the HHS and more of a coma state. Polyuria is going to be the presenting symptom in HHS, whereas DKA has more of the abdominal pain, nausea, and vomiting. The treatment is that's the same for both. So you're going to want to hydrate. I put this in caps on the HHS side because you can actually improve the blood sugar a lot just with hydration in these patients. But you will do an insulin drip, and you'll do it in the same way, put the 0.1 units per kilo per hour. But since we're not monitoring an anion gap, when do you stop the insulin infusion for HHS? So you want to check the serum osmolality, make sure that that's normalized, and that the patient has an improvement in their mental status. And then, so once the patient's better, you want to talk about prevention. So educate your patients on the importance of blood sugar control. Keep in close contact. Tell them to keep in close contact with their PCP, or if they have an endocrinologist, when their blood sugars start to increase, give them a call. And then teach them the warning signs about DKA. So the frequent urination, the weight loss, the sleepiness, and excessive thirst. So what happened to our patient? So she had a UA with a UTI, and she actually had a CT as well that showed pyelonephritis. She was treated with antibiotics. She got better. Her DKA resolved. She was sent home. So take-home points. So like I said, the first thing is your ABCs, and then where the C, circulation, hypovolemic shock may occur. You have to fluid resuscitate these patients in the beginning. Make sure your potassium is adequate before starting your insulin. Avoid decreasing the insulin drip prematurely. So IV fluid with dextrose is your friend. And then make sure to find that underlying etiology that can be treated. And the HHS differs from DKA from the much higher glucose, absence of ketones, hyperosmolality. I think that's my last, yeah. That's the last thing. Does anyone have any questions? Thank you.
Excellent work.
Thanks.
Thank you. Thank you for participating in our Nuts and bolts.